Welcome back to Council in Your Neighborhood. I'm your host, Martavius Jones, Memphis City Council, Super District 8, Position 3. As you know, we're working especially hard to get Memphis back to business, but we also want to make sure that we do so in a safe and healthy way. And to help in some of those discussions and some of those deliberations as to how to best reopen the economy, I have asked Dr. Bruce Randolph, the Chief Health Officer for Shelby County, to join us on today for our Council in Your Neighborhood. So you don't want to miss any of the show. Stick around. We'll be right back after this short break. Okay, as promised, we're back and we are interviewing today for Council in Your Neighborhood, Dr. Chief Randolph. He's the Chief Health Officer for Shelby County, Tennessee. Dr. Randolph, welcome to Council in Your Neighborhood.
Well, thank you, and thank you for the invitation to be here.
Well, I don't know if we've met in person, but I know that you've had a lot of FaceTime in Memphis and in Shelby County recently. But for some of those who may not be familiar with you, tell us a little bit about your background.
Well, I'm currently the health officer for Shelby County Health Department. Prior to coming aboard April 1st, 2019, I was in private practice here in Memphis, specializing in occupational medicine.
Okay.
And have worked in that area for over 20 some years. Moved here from Oklahoma back in 1996 and have been in and out of Memphis and since then.
Okay. Well, great. So you are, it's not like this is new to you anymore, just the responsibility. Now, how is this job that you're in now a little bit different from private practice?
Well, the thing is occupational medicine is a subspecialty of preventive medicine.
Okay.
Public health, general preventive medicine and public health is also a subspecialty of preventive medicine. And so my training, actually, I started out in my professional career in public health. Okay. So I'm returning back to my roots, so to speak. The difference is in occupational medicine, the population that I'm concerned with are workers.
Okay.
And within the workforce. Now the population that I'm concerned with is the general population, not only workers, but people at large.
Okay. Well, I'm sure at some point when we get out of the woods of this, you may have weekends off, but I can imagine that since March, or was it before March, that you all really started working in earnest on tackling how best to handle this COVID-19?
Yeah, at the beginning of March, we started looking at it. And when we got our first case, I think it was around the 8th of March, that we really went into full response and actually established incident command system to address the COVID-19 pandemic. And we've been working 24/7, basically 7 days a week since trying to contain and mitigate this problem.
Well, and I'm sure it has affected everybody's daily lives. And part of our getting back to work is going to be dealing with some of the data. So what's some of the data that you and other health professionals and other professionals who are part of the task force, what's some of the data that you guys are looking at to determine when it's safe, or what do we have to do in order to get some sense of normalcy back with us?
There's a few key points. One is the rate of new cases. Each day as we test more, we're going to get more cases, but it's that rate of increase from these days that we're looking at. We're also looking at the capacity for hospital beds, particularly ICU units, and our level of capacity to be able to respond to a surge. Importantly is our capability to test identify and isolate those who are positive, and also contact and trace those who are contacts. That's going to be very crucial in terms of trying to contain and limit the spread of this virus as we open up.
Okay. Well, now that rate of increase, have we seen a rate of increase? Has it been steady? Have we yet to see a decline yet?
We see a steady.
Okay.
It hadn't declined to the point where we would ideally love it to be, but it's not increasing. It's sort of a steady state. So, but we're monitoring that.
Okay. Now, regardless of what news source you look at, you're going to see that's going to be the main topic that's dominating the headlines, talking about the number, whether it's increase, decrease. So one of the things that I saw yesterday, that number of positive tests, is that directly related to the number of testing? There's been some talk about we don't have enough tests. Do you know if we would still, and I know this is speculation at this point, do you think we would still see a steady number if there was an increase in the number of testing that we'd see?
Right. So, and what you're referring to is the positivity rate.
Okay.
Right. What percentage of the tests that's performed turns out to be positive? It turns out now that we're somewhere around 7.5%, which is decreased while we're at 10%.
Okay.
The thing is that as you do more testing, and depending on who you're testing, so testing people who have symptoms and more likely to be infected, your positivity rate is going to be higher.
Okay.
As you start testing asymptomatic people without any symptoms, and broadening your testing population, your positivity rate is going to decrease.
Okay.
And the thing is that, we have tested now around 45,000 people.
Okay.
But we still need to test more in a more diverse population to get a better picture of what is the true positivity rate.
Okay. So when you say a more diverse population, would that be older people, younger people, just different neighborhoods? Can you talk about that a little bit, please?
Exactly. So we're talking about not only people who have symptoms, who are more likely to be infected, especially if they have symptoms that sort of correlate with the COVID disease, but also older population, also healthcare workers, also people who work on the front line, so to speak, that work in jobs that place them at of exposure, population testing, just the general population, people in not only out east, but in South Memphis, North Memphis, and other areas. So geographically, demographically, asymptomatic, symptomatic, just a whole variety of people to give us a true picture of what is the prevalence, what is the positivity rate that exists.
So, and correct me if I'm wrong, the people that have mostly been tested now have been people who have shown some type of symptoms. These have not been asymptomatic people. Is that correct?
Correct.
By law.
Right. And part of that was because initially we had limited testing.
Okay.
And so we wanted to first make sure that there was a criteria that you had to meet, fever, cough, shortness of breath, difficulty breathing, travel to certain areas that had a high disease. Now, as we begin to expand and also realize that there are a considerable number of people who don't have those symptoms who test. So now we're beginning to expand that criteria, and certainly we want to screen healthcare workers, first responders, people who are out front, who's going to be encountering people. But we're beginning to now look at testing people who may just have some mild symptoms. For instance, some people who the only symptom they may have is, hey, I've lost a sense of smell and taste. Don't have the fever, don't have the cough. We're testing those people too.
Okay. Now, and I would imagine, particularly with the cough, some of the seasonal allergies have made people maybe have provided some type of false uh, sense of having some symptoms of COVID-19. Has that been the case? Any?
But yeah, and especially, I mean, now that the flu season is not with us, but even when it was, that was always the issue, right? Okay, so is this cough, runny nose fever?
Hmm.
Is it allergies? Is it COVID? And the only way that you can absolutely know would be to test.
Okay.
To um, and so yeah, so that is kind of the concern. Certainly, people should not reach the conclusion that, oh, I got a cough, I must have COVID-19. That may not be the case.
Okay. Okay. Now, um, I guess so. Asymptomatic means that people are not showing any of those symptoms that you just mentioned, but they still are, or they still would test positive for it. And there's been some concern that asymptomatic people can still transmit or transmit the disease from themselves to somebody in their close surroundings. Um, what's being done to, or if anything, what's being done to test asymptomatic people?
Well, that's an area that we need to expand into, actually, and
Okay.
moving that. But for example, when we even do our investigation of a case, one of the things that we do is ask, when did you become symptomatic?
Hmm.
And then we go 2 days beyond that, backwards to identify people who may have come in contact, because it is showing that people may be spreading the virus before they develop symptoms.
Okay.
Yeah. And so and that is a concern.
Okay. Okay. Excuse me. Now, one of the things that I've heard about too, um, I actually saw something online, an online course, a greater demand for contact tracers. Talk a little bit more about what contact tracing is and what that entails.
Okay. So in order for us to be able to move into reopening our economy back to business, right? There's a couple things that's essential, especially when you have a disease that you don't have vaccination for,
Hmm.
you have really any medication to treat it. Then the only way that you can respond to this is trying to retain, mitigate, and contain it, keep
Okay.
it spreading. The way you do that is first you have to test people to find out who's infected and who's not. Those who test positive, which means that they're infected, you have to isolate those. Then you interview those individuals and find out, okay, who did you come in contact with during this period of time that you could be passing the virus on during your infectivity period. Then when they identify these people who may have been exposed, those are contacts. We interview them and place them in quarantine, and we monitor them. And that's what a contact tracer is, someone who will identify people who may have been exposed,
Hmm.
them, establish contact with them, and monitor them to make sure that they are okay, that their needs are being met, and whether or not they have now developed any symptoms. The whole idea is isolation means putting someone who's already infected away, separate from the population that's not infected. Quarantine means putting someone who's been exposed. They're not infected, but they may have been exposed. You putting them away from the general population to determine whether or not they will develop infection later. And so that's why we have to quarantine and isolate.
Okay. And I'll be the first to say that I was a bit confused. I thought that quarantine and isolation meant the same thing, and those terms could be used interchangeably. But thank you for clearing it up,
Yeah,
clarifying, letting me know, and maybe informing others that they are not the same thing.
right.
So somebody who's been quarantined, they have been exposed and they have COVID-19.
No, someone who's quarantined is
Yeah.
someone who's been exposed. They may or may not have it. We're observing them to see
Okay.
develop it.
Gotcha. And so,
Someone
no, I'm sorry. Go ahead.
someone who's in isolation, they have it.
Oh, okay. Okay. I had the other one right. Gotcha. So
Yeah.
in isolation, they have it. Gotcha.
Yeah.
Okay. That's where my confusion was lying. So we talk about once somebody has been isolated or even quarantined, that's when the shelter in place and then the safer at home strategies to mitigate this came about. Do you think that those two strategies of combating this outbreak, do you think that those were effective?
I think so, because what it has done is has bought us some time. The
Okay.
whole idea was what was tried to avoid is a surge that would overwhelm our healthcare system.
Okay.
Okay. We know that an X number of people are going to get infected. Okay. Currently, so even if the positivity rate, let's say, is 7%,
Mm-hmm.
you can kind of estimate this. Okay, 70% of the population may get infected. The thing is that if that 7% one time, that would overshadow our healthcare system.
Yeah.
And so by doing these things, you're spreading out, you are hopefully limiting the transmission, and you're spreading it out to give you more time. It's better to see 10 people over a period of time than 100 at one time.
Right.
Yeah.
Now, most of the time that I'm driving into the office, my office is downtown, and I pick up my Starbucks at Cleveland at Union and McLean. So I passed what was the old commercial appeal building. So what's being done, that's been set up as a center for treat. Is that going to be for isolated patients or quarantine patients, or both?
It's going to be for patients who've been diagnosed with COVID-19.
Okay.
Who are too ill to be home. Now, most people who get infected have mild to moderate symptoms, and they can stay at home.
Okay.
Right? They don't need to be hospitalized. But there are some who will be too sick to be at home, but not severely sick enough to occupy intensive care unit.
Okay.
And so we needed a place to put those types of patients in anticipation that we have this surge that has been projected through various models to occur at the end of May or 1st of June.
Okay. And so were there any, or I'm ashamed that I hadn't followed this stat. I know that nationwide, some of the projections have been adjusted upward. Have our projections stayed the same as they were earlier? Have they been adjusted upward or downward? What's been the case here locally?
In terms of the projected number of infections, there's several models, and pretty much it turns out that so far they don't seem to be as bad as we initially projected.
Okay, well, that's
the result of our efforts and people complying with the recommendations of staying home, wearing your mask, safe distancing, and those types of things. That I think we're seeing an effect that we're not seeing the catastrophic outcome as initially projected, but we're not out of the woods yet.
Okay.
Yeah.
Well, no, I think that's worthy of repeating. What was that last phrase you just said?
We're not out of the woods yet. That's right.
Because, as I've followed this subject for a couple of weeks now, if we're looking at today, we really won't have an accurate snapshot of today until 2 weeks from now. Is that correct?
Exactly, because The incubation period for this virus is up to 14 days, right?
Mm-hmm.
So, we open up on the 4th of May.
Mm-hmm.
It's phase 1. Well, we won't really know the outcome of that until about the 18th of May. About 14 days later,
which would be Monday.
Right. We'll start seeing, okay, well, was there a uptick in cases, hospitalizations, of what? Are things steady, right?
Okay.
So so you're right. So what we do today will be seen 14 days from now.
Okay. Because I think I saw a news report either last night or today talking about that 14 days being up, and I think there may have been an expectation that come Monday that you and Dr. Householder would essentially say, Monday, this is the day, and we're just going to open it up. We're still going to look at data from today, from Saturday, from Sunday, before you make a determination. So you have a full 14-day picture. Is that correct?
Correct.
Okay.
And we're looking to see based on what the data is showing us, do we just continue where we are? Do we move to phase 2? Or do we say, you know what, we might need to back up a little bit?
Okay. And so that is on the table. So now, if we back up a little bit, that could possibly be contrary to what's taking place at the state or the national level. And so the question that I have would be, I know that you and Dr. Householder, as the medical professionals, you're going to make what is your best determination based upon public safety. But from an economic standpoint, how do we juxtapose that? And do we listen to what may be the political will, or do we look at the scientific will? So I know that you're going to have your opinion. You are going to have your opinions on that. How would you advise us, as me as the elected officials and others, to navigate those balancing acts?
Well, I think you have to do a cost-benefit analysis, really. I mean, you have to take into account the data. Of course, from our perspective as public health officials, our position is we want to promote, protect, and improve the health of the citizens of Shelby County, and we'll be pushing to do what we feel is in the best interest of the people. But the policymakers are the one who ultimately makes the decisions.
Okay.
And they have to weigh all of that.
Yes.
That decision, right?
Well, I really hope that they listen to you and the health experts, because a story that I saw a couple of weeks ago, like I said, as you well know, it's been dominating the headlines. I guess we have a new perspective of what's considered essential work and essential workers. And those people or those occupations that are essential aren't necessarily those that are the highest paying or the higher paid professions and job functions. So we really have to weigh that. And a lot of people may think that we are sacrificing those who are now essential workers to open up the economy for those whose jobs have proven to be not as essential once we look at a situation like this.
Well, yeah. I mean, one thing that this virus has done is brought out some of the disparities and inequities that exist within our society and the workforce.
Mm-hmm. Mm-hmm. So going forward, I know there's been talk about whether there's a vaccine, and we could be looking at round 2 from the fall, especially when flu season kicks in. So what are some of the things that we're going to be doing between now, over the summer, before fall gets here, to sort of be ready for any type of challenges that we may have later in the year?
Well, I think on a national level, of course, there's, vigorous efforts to find a vaccine and to come up with some treatment. Various studies are being performed looking at different medications, truth of the matter is that if the projected time for having a vaccine is very optimistic,
Mm-hmm.
and I think it would be a great feat if indeed we have a vaccination within a year.
Yeah.
Then that is going to bring about some challenges. And so, the truth of the matter is currently what we're doing now, we just going to have to really reinforce and become committed to, hey, for a while, this is a new way of life.
Yeah. Yeah.
Wearing that mask in public, watching the large crowds,
Mm-hmm.
trying to keep your distance and washing your hands and all that. It's going to become a way of how we have to do things now.
Yeah, that's a new normal. A new normal for me, when I'm getting ready in the morning and coming back, walking in this morning, I realized that I left my sanitizer. I have one of those small sanitizers that I can keep on my belt loop. And so this morning I walked in, but my normal course of business now has been keys, wallet, sanitizer. Keep the mask in the pocket, but keys, wallet,
Right.
sanitizer. But I guess it's going to be that's our new normal, at least until the fall or whenever there's a vaccination or some way to come to this.
Yeah.
Yeah.
Exactly.
So who else on a local level are we working with? One of the things that I saw in some of the news coverage earlier this week, and this was looking at the subject of testing again. Are there Where do we want to be? Where do we want to be as far as the number of testing, the level of testing, and what's keeping us from getting there?
Well, one of the problems that we'll have is that our current capacity, we have a lot of sites that we have established.
Mm-hmm.
One of the issues is that they're not being utilized as much as they ought to. A little over just 40% utilization of what we currently have. And so we really, need people to utilize the sites that we currently have. We've partnered with a lot of some community partners like Christ Community, like some of, Memphis Health Center, the Baptist UT, and various other Methodist, other entities that have established testing sites. And we ourselves, the health department, will open up 2 testing sites as well to make the testing available.
Mm-hmm.
And I want to make sure, though, is that we have sites in the high-risk communities and make it more, especially as we expand to testing asymptomatic people,
Mm-hmm.
easier for people to be tested so that we can get a true picture of where this disease is, who's infected, and that the numbers really represent the true picture.
Mm-hmm. So what do you think? Well, I guess, and this is just from the outside looking in, looking at a utilization level of just 40%, I would think that the impression in our community may be, well, if I don't have symptoms, well, I can't be tested or I shouldn't go to get tested. That still is the case that most people have to show some symptoms in order for that to be the case. And if the population at large is more asymptomatic folks versus symptomatic folks, aren't we still going to have that utilization challenge?
Well, yeah, and that's the reason why I am a proponent for now moving towards asymptomatic.
Okay, I'm glad to hear that.
Yeah, that we move towards asymptomatic. Now, one of the issues is we still don't have an abundance of testing kits.
Okay.
The swabs and things like that is still somewhat limited, but become more and more available. I'm certainly of the position that we need to move towards, hey, if you've been around someone who's who is COVID positive, you should get tested.
Okay. That's encouraging to hear.
Yeah.
Each week, since this will probably take place for about 6 weeks now, but every Thursday the mayor gives my colleagues an update. And so once I learned that asymptomatic people still have the ability to pass on the disease, I have been concerned that we haven't been doing enough asymptomatic testing. So any closing words that you would like to say to the audience, or I would like some advice of what I can do to help spread the message as a council person to help our community?
Well, one of the things is that I'm very, very interested in trying to get the message out to the African American community. As you well know, 6 to 8% of the cases occurring among us. There's numerous reasons why. I mean, it's not just what we are not doing, but there's some other contributing factors that have attributed to this disparity in health care and health status throughout Shelby County and state and country as well. So one of the things is that I'm certainly interested and invite anyone to contact me to see how we can work to get the message out that stay safe, stay home if you have to. If you're out in public, in the stores and stuff, wear your mask, because what we want to do, the way that we're going to protect each other, I got to keep mine spit and respiratory fluids to myself, and the other person got to do the same, so that we're not spreading it.
Yeah.
And so the mask, safe distancing, trying to avoid large crowds. If you're at risk, if you got diabetes, heart disease, anything like that, you really need to be careful. Look at the numbers.
Yeah.
Cardiovascular disease is one of the most risk factor attributed to the deaths associated with COVID-19.
Okay. Well, Doc, you have been quite a help to me. I hope that this broadcast will help inform some of the public about what we faced, where we've gone, where we've come, and what's ahead. So thank you for taking time out of your busy day. I know this is going to be quite a weekend for you with our 14 days wrapping up. But so I just want to say thank you. Martavius Jones, want to wrap up. Our guest today has been Dr. Bruce Randolph, who is the Chief Health Officer for Shelby County, Tennessee. Thanks again, Doc, for joining us and informing us.
Thank you for having me, and be safe and have a blessed day and weekend.
I will. Thanks a lot.
All right.
Bye-bye.
Bye.